Hello class, this is chapter 41 of Emergency Care and Transportation of the Sick and Injured, and this is a team approach to health care. We're going to be discussing by working as a team how health care is improved, and along with delivery and coordination of care, improving survivability and recovery of patients. You are a critical member of the emergency healthcare team overall, from the ground to the hospital. By working as a team, emergency healthcare providers can improve patient and provider safety and deliver much better emergency care. Community paramedicine and mobile integrated healthcare, or MIH teams, may be the best examples of the team concept of continuum of care. The structure and effectiveness of emergency healthcare teams differs from system to system through the country, but overall, the goal is the same and most policies and procedures are the same. There are regular teams where EMTs are consistently interacting with the same partner or team. Then there are temporary teams where EMTs work with providers with whom they do not regularly interact or may not even know. With special teams, you have fire teams, rescue teams, hazardous material or hazmat teams, tactical EMS teams, special event EMS teams, EMS bike teams, in-hospital patient care technicians, and MIH technicians. A group consisting of healthcare providers working independently to help the patient include triage teams, treatment teams, and transport teams. A team consists of a group of healthcare providers who are assigned specific roles and are working interdependently in a coordinated manner under a designated leader. The 5 essential elements of a group include a common goal, an image of themselves as a group, quote unquote, a sense of continuity of that group, a set of shared values, and different roles within the group that are each understood and how they are interdependent. Dependent, independent, and interdependent groups is what we're going to discuss now. In dependent groups, each individual is told what to do, how often to do it by his or her supervisor or group leader. In independent groups, each individual is responsible for his or her own area, either a physical space or a set of tasks. They may receive supporting guidance from a supervisor or a group leader, but they do not have to wait for an assignment before taking an action. EMTs and other healthcare providers who work interdependently are functioning as a true team, where each provider may be assigned to a particular area or task, but everyone works together with a shared set of responsibilities, accountability, and a common goal, as opposed to focusing on the goals of their own individual areas. For there to be effective team performance, there must be a shared goal, and every healthcare provider on the team must be committed to a common goal, which is typically the best possible patient outcome, which naturally is what it should be. There are clear responsibilities and roles for everyone, and each provider must know what needs to be done and what is expected of him or her. Diverse and competent skill sets are necessary. They need to be practiced with one another, and they need to become familiar with each other's tools, techniques, capabilities, and preferences so that each member is competent before the call comes in. Effective collaboration and communication are important, and 4 important elements of team communication include a clear message, speak calmly, confidently, and concisely. There should be a closed loop of communication. Repeat the message back to the speaker, so that way it's clear that you've understood them clearly and they've spoken clearly to you, and you both know exactly what the other one means by intent and by speaking. Also, use courtesy, speak politely, and use constructive intervention if it's necessary. Respectfully question or correct a team member or the team leader if a mistake has been made or it is about to be made. Be respectful, but just remind them. Use a question like, isn't it necessary that we stabilize the neck before we do so and so, for example? That might be one way to ask. Also, there should be supportive and coordinated leadership. The team leader provides role assignments, coordination, oversight, and centralized decision making, and support for the team to accomplish their goals and achieve desired results. This is often defined by policy, procedure, or even statute. And it may be the most senior level person with the highest level certification. Team leaders foster communication and team dynamics using concepts such as crew resource management and team situational awareness. Situational awareness is the knowledge and understanding of one's surroundings and the ability to recognize potential threats to safety. Crew resource management, CRM, is a way for team members to work together with the team leader to develop and maintain a shared understanding for or of the emergency situation. CRM recommends the use of the PACE mnemonic. P stands for probe, look or ask to confirm the problem. A is alert, communicate the problem to the team leader. C is challenge. If the issue is not corrected, then clearly challenge the team's present course of action that is leading to the problem. And E is emergency. If the problem is clear and critical, then immediately communicate the emergency to the entire team. Remember, that's the mnemonic for PACE. Probe, alert, challenge, and alert to the emergency. Now let's discuss transfer of patient care. At several points along the continuum, the patient's care will be transferred or quote-unquote handed off from one unit of providers on the team to another. These transfers introduce the possibility of critical patient care errors, especially when they occur several times and in different settings along the continuum of care. A mass casualty incident might be one example where you could see this potential problem. That's just one example. Effective teams minimize the number of transfers during patient care and adhere to strict and careful guidelines when such transfers are unavoidable. Whenever verbal transfer of care occurs, all team members should do their best to ensure the following: uninterrupted critical care. Whenever possible, the team member giving the report and the team member taking the report should hand off life-saving care to another team member, allowing them to focus on the transfer of care. Minimal interference. The transfer of patient care should occur in a location with the least interference possible. Respectful interaction. Each team member involved in the transfer must be respectful of the members' different roles and recognize the importance of each role. And there should be common priorities. Both the team member giving the report and the team member taking the report must focus on their common priorities, which are critical assessment findings and patient care, which are vital for the best possible patient outcome. And there should be a common language or system. Whenever possible, a mutually agreed upon and standardized patient handoff format should be used. You need to refer to Chapter 4, which is Communications and Documentations, for information on PCRs. Now let's talk about BLS and ALS providers working together. BLS and ALS care cannot exist without each other. BLS efforts must continue throughout the continuum of care. You must carefully coordinate your efforts with the advanced tools and techniques used by ALS providers. What may be quote-unquote paramedic-only skill in your EMS system may be common for an EMT to perform in another. It is your responsibility to understand what is allowed by the scope of practice, standard of care, and local protocols where you work. If you work outside these bounds, then you risk a strict legal liability. There are many ways in which you can assist paramedics and other ALS providers with advanced procedures, however. Assisting with ALS skills. Assisting allows a 4-step process, which is patient preparation, equipment setup, performing the procedure, and continuing care. You can assist with placement of advanced airways. Endotracheal or ET intubation is the insertion of a tube into the trachea to maintain and protect the airway of the patient. The ET tube can be inserted through the mouth or through the nose. With patient preparation, the more oxygen that is available in the alveoli, the longer the patient can maintain adequate gas exchange in the lungs while the intubation procedure is being performed. So there's pre-oxygenation, where you maintain a high-flow nasal cannula on the patient during the pre-oxygenation phase and leave the nasal cannula in place during the intubation attempt. Apneic oxygenation is just the opposite. Now, with equipment setup, it typically includes personal protective equipment, PPE, a suction unit with a rigid tonsil tip and non-rigid whistle tip or French catheter, a laryngoscope, handle and blade, and that is sized for the patient, Magel forceps, an ET tube that has been sized for the patient, a stylet or tube introducer, which is gum and elastic boogie, and then water-soluble lubricant, 10 milliliter syringe, a 10 milliliter syringe, and confirmation device or devices including waveform and end-tidal CO2 monitors and or colorimetric device, a commercial ET tube securing device, and alternate airway management devices such as supraglottic airways and or cricothyroidotomy kits. Performing a procedure with advanced airway as an assist, be magic. In other words, perform BVM pre-oxygenation, evaluate for airway difficulties. M stands for manipulate the patient. A, attempt first pass intubation. GI, use a supraglottic or intermediate airway if unable to intubate. And C stands for confirmation that you have successful intubation. Be magic. With BVM pre-oxygenation, it is crucial that you adequately pre-oxygenate the patient before intubation procedures take place, but do not hyperventilate the patient. Focus on maintaining a good seal, achieving chest rise and fall, and delivering breaths at a rate appropriate for the patient's age. Evaluate for any airway difficulties. Assist the ALS provider with evaluating the patient to identify any factors that may present difficulties during the procedure, for example, trauma or anatomic deformities to the airway. When manipulating the patient, you want to position the patient so that the ALS provider can visualize the vocal cords. And then attempt intubation. Remove the oral airway and disconnect the mask from the bag in preparation for connecting the bag to the ET tube. Keep suction equipment at hand, and the ALS provider may ask you for assistance in manipulating the patient's larynx or otherwise positioning the patient for a better view. Should the intubation attempt fail, it may be your responsibility to prepare and hand over the supraglottic or intermediate airway device. Confirm intubation and correct issues, so you may need to watch the end-tidal waveform CO2 detector in line between the ET tube and the bag. You may also either ventilate the patient while another provider checks for positive breath sounds in the absence of gastric sounds, or you may listen while another team member ventilates. If intubation is confirmed, you may assist in securing the ET tube. If intubation cannot be confirmed, you may have to assist other team members in correcting issues. With continuation of care in advanced airway assisting in ALS, you must continue to observe all of the patient's monitor readings as well as monitor for signs of potential complications, including absence of end-tidal CO2 level, decreasing SpO2 level, increasing resistance when ventilating, or other physical signs of poor ventilation and perfusion. You may also observe improper positioning or dislodgement of the ET tube. Now, as far as vascular access, a procedure that gains access to a patient's circulatory system in order to inject or remove fluids, medicines, or blood products is vascular access. And of course, that is ALS. However, you can help to prepare. So with patient preparation, this may be involving you positioning the patient and equipment, and you may also be involved in explaining the procedure and the reason for it to the patient and ensuring that the patient is comfortable and calm. With equipment setup, while a vascular access may involve either IV or intraosseous access, the procedure and equipment list will generally be the same. You need PPE, including properly sized gloves, a properly sized bag or syringe of the IV solution selected by the ALS provider, tubing and a drip set selected by the ALS provider, skin preparation pads, typically alcohol prep pads and or a betadine solution, adhesive tape torn into several pieces about 1 inch or 2.5 centimeters in length, gauze, which is typically 2 by 2 inches or 4 by 4 inches, and commercial IV securing system. You also may need an IV with a pigtail catheter. Now, if IV access is necessary, then a venous constricting band, sometimes referred to as a venous tourniquet, will be necessary. An IV catheter selected by the ALS provider, and if it's intraosseous access, there will be needed an IO needle, and the size will be selected by the ALS provider, and a mechanical IO driver or insertion device depending on the IO system, and that will also be chosen by the ALS provider. Now, with spiking the bag, you need to remove the rubber pigtail found on the end of the IV bag by pulling on it. Remove the protective cover from the sterile piercing spike. Slide the spike into the IV port bag or into the IV bag port until you see fluid enter the drip chamber, then invert the bag. Squeeze and release the drip chamber until it's about half full. Unclamp the tubing and let the fluid flow until air bubbles are removed from the line before turning the roller clamp wheel to stop the flow. Check the drip chamber. It should only be half filled. If the fluid level is too low, then squeeze the IV bag until it fills it. But squeeze it gently so you can monitor that, because it will fill the chamber quickly if you are too aggressive when squeezing the bag. If the chamber is too full, then invert the IV bag and squeeze the chamber to empty the fluid back into the bag. Hang the bag in the appropriate location with the end of the IV tubing easily accessible for both you and ALS. Choose the drip set indicated by the ALS provider and attach it to the fluid bag indicated by the ALS provider. Fill the drip chamber halfway by squeezing it. Flush or bleed the tubing to remove any air bubbles by opening the roller clamp. Make sure no bubbles are floating in the tubing. And then with a saline lock or a buff cap, you can access devices used to maintain an active IV site without running the fluids through the vein. These are used primarily for patients who do not need additional fluids but may need rapid medication delivery. Procedures will vary based on local protocol. When performing the procedure for vascular access, while the ALS provider is establishing an IV or IO access, you may help to stabilize the patient's limbs or provide him or her comfort and continuing care. Once vascular access is established, continue patient care by observing the access site for swelling, bleeding, discoloration, or leaking. Observe the IV tubing to see if it is improperly blocked, clamped, or kinked, or if the bag of IV solution has run out or is empty. Now, troubleshooting team conflicts. When a conflict occurs, keep in mind the following 5 techniques. Remember, no matter what, the patient comes first. Regardless of interpersonal conflicts that may arise, the patient's needs must always come first. Do not engage. If the problem causing the conflict does not directly and immediately impact patient care, then do not engage. Have the discussion after the call, when more positive communication may be possible. Number 3, keep your cool. Maintain your professional composure. If you feel that the conflict is over a critical component of patient care, then follow the PACE mnemonic discussed earlier. If it is not, then begin by taking a deep breath and slowly counting to 10. Separate the person from the issue. If the conflict arises from the behavior of another team member and the conflict cannot be delayed or avoided, then focus on the behavior itself rather than the individual. And then choose your battles. Remember, there is strength in the diversity of team members. Not everyone will work in exactly the same way, and that is a good thing. Avoid engaging in conflict over minor issues in patient care that center around one provider, quote-unquote, style over another. Now let's go over the review questions for this chapter. We'll start with number 1. Which of the following is a characteristic of a regular team? A, they serve a specialized role within the larger emergency healthcare system. B, these are members that consistently interact with the same partner or partners. C, the team performs special functions across geographic boundaries. Or D, regular teams are more common in volunteer EMS systems. This one should be pretty easy and straightforward. And it is B. Members of a regular team consistently interact with the same partner or partners. This allows them to perform as a seamless unit. Special teams serve a specialized role within the larger emergency healthcare team. Groups perform special functions across geographic boundaries, and temporary teams are common in volunteer EMT systems. Now, since we discussed the incorrect answers already when going over the correct answers, I'm just going to briefly recap them here. Number 1, which of the following is a characteristic of a regular team? A, they served a specialized role within the larger emergency health care system. Special teams serve a specialized role within the larger healthcare system, and that's given in their title. It's a specialized role. Special teams have specialized roles. B, members consistently interact with the same partner. That, of course, is the correct answer. C, the team performs special functions across geographic boundaries. Groups that perform special functions across geographic boundaries are specialized groups, or they may be ad hoc groups that have been pulled together for a really large situation like a massive wildfire or some type of national emergency. And D, regular teams are more common in volunteer EMS systems. These are temporary teams, and those are, again, because they're temporary teams, more common in volunteer systems. Review question 2. Essential elements of a group that people must share include A, focusing on individual goals, B, placing emphasis on one way of accomplishing a task, C, working with a set of shared values, Or D, promoting a personal identity. Remember, these are essential elements of a group that people must share. So if you think about the way that's worded, you should get the answer pretty easily. It is C. It is important for groups to have a set of shared values, or how the group wants to get things done. In a group, the focus needs to be on a common goal. Group members must have a sense of continuity, and remember that the group may work together more than once in different configurations. And finally, a group member should put forth an image of the group as a whole, not one individual person. So let's look at the incorrect answers. Essential elements of a group that people must share include A, focusing on individual goals. That's incorrect. Groups are groups by definition of the fact that they're focused together on a common goal. B, placing emphasis on one way of accomplishing a task. That's incorrect because group members must have a sense of continuity, and remember that the group may work together more than once in many different configurations. So there can be many ways of accomplishing a task. C, working with a set of shared values. That is, of course, the correct answer. While all of the other things may or may not be true, this is the most correct answer because you're working with a set of shared values overall, which are typically the best patient care possible. And D, promoting a personal identity. That's incorrect because a group member should put forth an image of the group as a whole, not one individual person. So while some of the other things are correct, again, the most correct answer is that as a group, you're working with a set of shared values. Number 3, members of an interdependent group. A, focus on the goals of their own individual areas. B, rely on the group leader for task assignments. C, have limited ability to adapt and deliver critical care, medical care, in an uncontrolled field environment. And D, work together with shared responsibilities, accountability, and a common goal. This will be easy if you remember that these are members of an interdependent group. If you remember what the definition of interdependent is, then you should get the answer pretty easily. And it is D. Members of an interdependent group work together with shared responsibilities, accountability, and a common goal. People who are part of an independent group focus on the goals of their own individual area. Individuals who are part of a dependent group rely on the leader for task assignments and have limited ability to adapt and deliver critical medical care in an uncontrolled field environment. But members of an interdependent group work together with shared responsibilities, accountability, and a common goal. If you've ever seen a video of a trauma team in action in an emergency room, that is a clear-cut example of an interdependent group. Absolutely clear-cut. They each have their roles and responsibilities, but they work together with those shared responsibilities and accountabilities. So that's one example that you can watch to really get a grasp of what that interdependent relationship is like. Also watch some videos of interdependent trauma teams out in the field. That will also give you an idea of how clear-cut this process needs to be and how important being an interdependent team is. So let's look at the incorrect answer. Members of an interdependent group focus on the goals of their own individual areas. That's incorrect because people who are part of an independent group focus on the goals of their own individual areas. That's an independent group. We're talking about interdependent. B, rely on the group leader for task assignment. That is incorrect because people who are members of a dependent group rely solely on the group leader for their task assignments. C, have limited ability to adapt and deliver critical medical care in an uncontrolled field environment. That's incorrect because people who are part of a dependent group have a limited ability to adapt and deliver critical medical care in an uncontrolled environment. And certainly in a trauma case, a multi-car collision, multiple casualty incident, it doesn't get any more uncontrolled than that. So that's why interdependency is so important, and why D is the correct answer, where you're working together with shared responsibilities, accountabilities, and a common goal. Question 4. When a team member speaks, you should repeat the message back to him or her. This is an example of A, closed loop communication, B, a clear message, C, constructive intervention, or D, courtesy. Again, this one should be pretty straightforward. You shouldn't have any effort getting this one correct. It is A, closed loop communication. This helps confirm that you heard and understood the message and will act on it. A clear message is delivered when you speak calmly, confidently, and concisely, so the information delivered or the action requested is clear to the listener. That listener needs to repeat it back to you, so that is that you know that they understood exactly what you said, and that is your closed loop. Constructive intervention takes place when it is necessary for you to respectfully question or correct a team member or leader. You extend courtesy when speaking politely to members of the group. Let's look at the incorrect answers. To review the question, when a team member speaks, you should repeat the message back to him or her. This is an example of A, closed loop communication. Again, that is the correct answer. B, a clear message. Well, that's sort of correct. A clear message is delivered when you speak calmly, confidently, and concisely, so the information is delivered or the action requested is clear to the listener. However, if they don't repeat the message back to you, then it's not closed loop communication. No matter how concisely or clearly you may have spoken, until they repeat exactly what you intended to say back to you, you don't know how perfectly clear you were or not. C, constructive intervention. This sometimes is necessary where construction intervention takes place when it's necessary for you to respectfully question or correct a team member or leader. But again, we're talking about closed loop communication only here. While this is a useful process, it is not closed loop communication. And then D, courtesy. You should always extend courtesy and speak politely to all members of the group. But again, we're strictly talking about closed loop communication. 5. A team leader, A, helps individual team members to work together. B, is often defined by policy, procedure, or statute. C, provides coordination, oversight, centralized decision-making, and support for the team. Or D, all of the above. Let's take a look at this one. It is D. A team leader is an essential part of a successful team. The team leader is often defined by policy, procedure, or statute. He or she provides coordination, oversight, centralized decision-making, and support for the team. In addition, the team leader will help individuals to not only do their jobs, but also to work together. The perfect example I can think of a team leader is, for instance, a sergeant in the Army or a chief petty officer in the Navy. They are the quintessential team leaders, or a gunnery sergeant in the Marine Corps. Those are the quintessential team leaders. They see the entire picture. They know policy, procedure, and statute. They provide the coordination and oversight and centralized decision-making in the field. So here also, this is the civilian side of that very same concept, where a team leader, again, is an essential part of a successful team. The entire team is going to reflect on that team leader, and that team leader is defined by policy, procedure, or statute. And then he or she provides proper coordination, oversight, centralized decision-making, and support for that team. In addition, the team leader will help individuals not only to do their jobs, but help motivate people to work together. Let's look at the incorrect answers. A team leader, A, helps individual team members to work together. That is the correct answer. A team leader does help individual team members to work together. So that is correct. B is often defined by policy, procedure, or statute. Again, that is also correct, and we've already discussed this. C provides coordination, oversight, centralized decision making, and support for the team. That is also correct. But then, of course, D, all of the above, is the most correct answer. Number 6, the mnemonic B Magic helps you remember the 6 typical steps of endotracheal intubation. Which of the following is not part of the mnemonic? A. Performing BVM preoxygenation. B. Achieving venous access. C. Manipulating the patient. D. Evaluating for airway difficulties. This should be easy. You're talking about endotracheal intubation. So the incorrect answer should be glaringly obvious here. And it is B. Although a patient who requires endotracheal intubation will also require venous access, gaining venous access is not part of the B Magic mnemonic. B Magic refers strictly to endotracheal intubation. Performing BVM preoxygenation, manipulating the patient, and evaluating for airway difficulties are components of the B Magic mnemonic. So let's look at the incorrect answers. The mnemonic B Magic helps you remember the 6 typical steps of endotracheal intubation. Which of the following is not part of the mnemonic? Of course, performing BVM preoxygenation is important, and it is part of it. Achieving venous access is not part of the mnemonic. C, manipulating the patient is correct. You may have to manipulate the patient for proper intubation to take place by the ALS. And then also part of that mnemonic is E, evaluating for airway difficulties. So know your mnemonics and make sure you remember what each letter stands for in each mnemonic for each different process that it applies to. Question 7. As you ventilate an intubated patient, which of the following observations would cause you to immediately alert the team leader? A. Ventilation is creating equal chest rise. B. The patient's cyanosis is disappearing. C. The oxygen saturation level is now at 94%. Or D. The BVM is offering more resistance. This one should be pretty obvious. And it is D. Increasing resistance while ventilating with BVM could be indicative of a critical airway or breathing problem, such as an esophageal intubation that needs to be addressed. That's where the endotracheal tube ended up in the esophagus rather than in the airway. And other observations that need to be immediately reported to the team leader include decreasing pulse ox or SpO2 level, especially if it hits below 94%, physical signs of poor ventilation and perfusion, and improper positioning or dislodgement of the ET tube. Let's look at the incorrect answers. To remind you, as you ventilate an intubated patient, which of the following observations would cause you to immediately alert the team leader? Ventilation is creating equal chest rise. Equal chest rise is a sign that endotracheal tube is in proper position. No alarm there. B, the patient's cyanosis is disappearing. That's also good news. Improving cyanosis means that the ET tube is in proper position and the patient is getting proper oxygenation. C, the oxygen saturation level is now at 94%. An increasing oxygenation saturation level is a sign that the ET tube is in proper position. So if it's 94% and increasing, you're good to go. D, the BVM is offering more resistance. That's the correct answer. There shouldn't be any resistance. If there is, something's going wrong. Proper emplacement of the tube or perhaps something else. So yeah, if you're getting more resistance after intubation with BVM, then you need to alert your team leader. Question 8. You are assisting the paramedic, or ALS, with vascular access. When you spike the IV bag, it is important for you to use the blank technique. A. Sterile. B. Clean. C. Aseptic. Or D. Reduction. It is A. Sterile technique involves thorough decontamination as well as the use of sterile fields around the procedure and sterile PPE. When you assist with ALS skills, such as spiking an IV bag, it is important for you to use sterile technique. Clean technique refers to minimizing the amount of pathogens or unclean materials that you pick up or transfer through the use of routine hand washing. Aseptic technique is often used for fast, invasive procedures, such as starting an IV line, and refers to techniques that help ensure that pathogens are not introduced anywhere in the procedure. And there is no reduction technique. So let's look at this a little more closely. 8. You are assisting the paramedic with vascular access. When you spike the IV bag, it's important for you to use A. Sterile technique. That is the correct answer. B. Clean. The clean technique refers to minimizing the amount of pathogens or unclean materials that you pick up or transfer through the use of routine hand washing. Clean is not sterile. Make sure you're very clear on clean and sterile and sanitary and unsanitary. Those terms are absolutely vital for you to have totally clear understanding of. C. Aseptic. This is often used for fast, invasive procedures such as starting an IV line and refers to techniques that help ensure that pathogens are not introduced anywhere in the procedure. But again, that's not sterile technique. That's aseptic. They're completely different animals. And D. Reduction. There's no such thing as a reduction technique. So that's completely out the window. Question 9. When verbal transfer of care occurs, all team members should do their best to ensure that A. The transfer of care occurs in a place where many staff members are present to hear. B. Life-saving care is not interrupted if it is being performed by the person giving the report. C. Everyone is respectful of each team member's role. Or D. Patient care is centered around what you believe is the correct treatment. So if you think back to what I talked about verbal transfer of care, then you should get this correct answer. It is C. Whenever verbal transfer of care occurs, all team members should do their best to ensure that each team member is respectful of each other. Transfer of care should occur in a location with as little interference as possible, and the team member giving the report and the member receiving the report on the patient should hand off life-saving care to another team member. Finally, it is important to remember that the team members involved in the transfer of care focus on doing what provides the best care for the patient. Let's look at the incorrect answers. To remind you, when verbal transfer of care occurs, all team members should do their best to ensure that A. The transfer of care occurs in a place where many staff members are present to hear. The rationale here, the transfer of care should occur in a location with the least interference possible. That is true. It's not necessarily the most correct answer, but it is true. Life-saving care is not interrupted if it is being performed by the person giving the report. That's not correct. Life-saving care should be handed off to another team member if someone is having to pass on information. You can't be doing CPR and passing off life-saving information at the same time. You need to. That's why you have a team. Hand off that life-saving technique so that you can ensure the best communicate and most thorough communication involving that patient goes from you as your team leader to the next team leader. C. Everyone is respectful of each team member's role. That's the correct answer. D. Patient care is centered around what you believe is the correct treatment. Team members involved in transfer of care must focus on their common priority, which is the best possible patient outcome, not about what you individually believe may be the best course of treatment. And remember, treatments are dictated by laws, protocols, statutes, etc. So bear that in mind. You may or may not agree with it, but you're legally obligated to stick to a certain set of procedures and protocols and statutes. 10. Your partner's working a 48-hour shift and has had little sleep. He disagrees with you over how to position the patient and how you should drive to the hospital. You should A. Follow your partner's orders and discuss the call after the patient's been dropped off at the hospital. B. Confront your partner about his or her behavior in front of the patient. C. Tell your partner he or she does not know what they're talking about. Or D. Ask the patient who he or she thinks is correct. I'm sorry to laugh, but that one seems almost funny. It's so ludicrous. So let's look at the correct answer. It is A. If the problem causing the conflict does not directly and immediately impact patient care, it is best for you to wait till after the call to discuss this matter with your partner. It's also important to not have a heated discussion in front of the patient. I would say it would rather diminish my confidence in an ambulance team if they had some kind of blow up right in front of me. It would only increase my anxiety as a patient. It's also important to not have a heated discussion in front of the patient, as I just said. And rather than contribute to a conflict, take a deep breath and count to 10. Let cooler heads prevail. And then finally, do not involve the patient in a conflict. It takes the focus off patient care, and that's what you're there for in the first place. Let's look at the incorrect answers. Again, your partner's been working a 48-hour shift and has had little sleep. He disagrees with you over how to position the patient and how you should drive to the hospital. You should A. Follow your partner's orders and discuss the call after the patient's been dropped off at the hospital. Correct answer. Okay, just keep in mind this person's overtired, overtaxed, probably badly in need of sleep, and unless it's directly impacting patient care, just let it roll off your back like water off of a duck's back, count to 10, get the patient to the hospital, and then deal with it. By then, everybody may have cooled off anyway. B, confront your partner about his or her behavior in front of the patient. Incorrect answer. Do not confront your partner in front of a patient. Always keep the focus on providing quality patient care. And I underscore that by saying quality and the most professional patient care. C, tell your partner he or she does not know what they're talking about. Really, that will blow things up in a split second. So rather than confront your partner, again, take a deep breath and count to 10. Focus on getting the patient to the hospital, and 9 times out of 10, by the time you've done that, the whole thing's already dissipated anyway. And D, ask the patient who he or she thinks is correct. Your patient is not there to play referee between you and your partner. Your patient's there because they need you and your partner's help. So don't ever be involving a patient in a personal conflict. Remain focused on the goal, and that is the care of the patient ultimately. So thank you for your time and attention, and we will see you next class. Make sure that you go through and learn and memorize your mnemonics. We covered a couple in this class, in this particular chapter, so make sure you review those and know them. Thank you again for your time, and we will see you next chapter.